Good morning, everybody. Thanks for letting me do this presentation. So as Lance said, I'm going to briefly talk about cholera and compare epidemics that took place both in Haiti and in Goma in Zaire after the genocide that took place in 1994. So first of all, I'm going to give you a brief overview of the pathophysiology of cholera and talk a little bit about microbiology as well. As you know, cholera is caused by a gram-negative bacteria by the name of Vibrio cholera. And there are two major strains that are responsible for some of the major outbreaks that have taken place. And they're primarily strains 01 and 0139. Strain 0139 was responsible for the outbreaks in both Haiti and DRC. So after ingestion, Vibrio cholera passes through the stomach and enters into the intestines, where it produces a cholera toxin which binds to gut epithelium. So there, after binding to gut epithelium, it causes an increase in cyclic AMP, which then causes an increase in chloride secretion, and you get inhibition of sodium chloride absorption. This then causes massive secretion of fluid into the lumen of your intestines, causing acute secretory diarrhea. So as a result, you get acute onset of perfused watery diarrhea. And for those of you who have treated cholera before, you all know that the consistency and the way it looks is very similar to rice watery stools. In addition to perfused watery diarrhea, you get vomiting, you get dehydration. And it's important to make a distinction between mild and moderate dehydration as well as severe dehydration, because that's going to direct how you treat a patient that has cholera. So for those with mild dehydration, mild to moderate dehydration, you have sunken eyes, decreased skin turgor, and you only have about 5 to 10% dehydration. For those with severe dehydration, dehydration as known as more severe with more increased skin turgor, sunken eyes, you get lethargy, anuria, which is basically inability to produce urine, an absent pulse, but also because of acidosis, you have something called Kussmaul breathing. So the person breathes extremely rapidly and takes very deep breaths to compensate for the acidosis. Also, you get electrolyte loss, you lose potassium, you lose bicarb, and you have a metabolic acidosis. So some of the complications, as mentioned before, hypokalemia, low potassium, hyponatremia from dehydration. You can get acute renal failure from dehydration, hypoglycemia. So for patients that have a history of heart disease, they're actually prone to developing ischemia, so heart attacks, as a result of just being in this very fragile state. But also, as you're rehydrating patients, one thing to pay close attention to is acute pulmonary edema from giving too much fluids. So let's talk about management. The first thing you want to do, as mentioned before, is you want to assess dehydration and whether or not a person has mild to moderate dehydration versus severe dehydration will direct your therapy. For those with mild to moderate dehydration, oral rehydration solution is enough, which they take orally by mouth. For those severe dehydration, you want to give IV fluids and antibiotics. And I'm going to talk a little bit more about zinc and who to give zinc and when to administer zinc. So this table just shows you characteristics of patients with mild versus severe dehydration and what to look for. The first thing you want to do is look at the patient, look at their general condition. If they're well and alert, responsive to you, and they don't have any signs of dehydration as mentioned, sometimes you can just give a little bit of ORS to match stool volume. However, if the patient is a little restless, has a little bit of sunken eyes, their pulse is weak but not absent, they have some skin turgor, and you classify them as being mildly to moderately dehydrated. You want to hydrate them with ORS, and you want to just observe them. For those with severe dehydration, patients that are lethargic, unconscious, they're unable to drink, you want to correct their hydration status very rapidly by giving them IV fluids. And so here is an algorithm which basically shows you how much ORS to give based on the patient's weight and their age. It's very, very simple. You want to address rehydration in the first 4 to 6 hours because that time frame is extremely critical. During that time, that's when they lose the most amount of fluid and they can actually die very quickly. This is a picture of a woman who was giving oral rehydration to her child at one of the clinics we had at the beginning of the epidemic in Haiti. And as mentioned, those with severe dehydration, you want to give them IV fluids very rapidly. For patients that are less than a year old, you want to give 30 mils per kilo in the first hour, followed by 70 mils per kilo in the next 5 hours. For those that are greater than 1, you're going to give fluids a lot more rapidly. So 30 milliliters per kilogram in the first half hour, followed by 70 mils per kilo in the next 2.5 hours. You want to assess the patient over and over again to determine whether or not they need that amount, same amount of fluids, or you can actually decrease the amount of fluids you want to give. And this is a picture of a child that had come in who was lethargic, unconscious, extremely dehydrated. We had to give her IV fluids. We had to place an IO in her leg. And she got better after being hydrated for many hours. It's really remarkable how quickly patients are able to recover after giving IV fluids. And we call it the Lazarus effect. Going from being unconscious to being able to just get up and walk, and that happens in a matter of hours. So it's extremely important to hydrate as quick as you can, but based on these guidelines. So in addition to rehydration, you want to give antibiotics. And antibiotics have been shown to reduce the duration and the severity of illness. And you only want to give antibiotics to those that are severely dehydrated. And it's extremely important to pay attention to sensitivity and resistance patterns in the country where the epidemic is taking place. And I'm going to talk about this in the Goma epidemic, where this actually did play a role. So some of the major antibiotics are listed below. The first one is doxycycline. You give a single dose of doxycycline at 300 milligrams, but you want to avoid giving doxycycline in both pregnant women and children. So the drug of choice for pregnant women and children is really erythromycin, and sometimes azithromycin based on the availability of the drug and, again, resistance patterns. So you give erythromycin at 12.5 milligrams per kilo, and you give 4 doses. The good thing about azithromycin is that it is a single dose, 20 milligrams per kilo. But azithromycin is usually a little bit more expensive than erythromycin and more difficult to find. Other drugs that you can give are ciprofloxacin at 15 milligrams per kilo twice a day for 3 days, or Bactrim, double strength twice a day for 3 days. The problem with Bactrim, though, is that because we talked about the fact that patients are in renal failure, I think it might be best to avoid Bactrim if possible, if you have other drugs available, given that you might make the renal failure worse. And finally, zinc. Zinc has been shown to reduce severity and duration of illness, and it's supposed to be given in children, all children that are 5 years and under. And it also decreases severity and the incidence of subsequent diarrheal episodes. And the dose is 10 milligrams once a day for 10 to 14 days in children that are 0 to 6 months of age, and 20 milligrams once a day for 10 to 14 days in children that are 6 months to 5 years old. So this is a concept that I was introduced to by Dr. William Greene, who is a faculty member here at Hopkins and has done extensive research on early feeding and home-based ORS. He's actually the one who discovered oral rehydration therapy. And oral rehydration therapy is probably one of the most important medical advances of the last century because, with the creation or the discovery of oral rehydration therapy, many lives have saved. We know that in a lot of underdeveloped countries, acute watery diarrhea is one of the major causes of death, and being able to have access to oral rehydration at home really is able to save lives as a result of not having to go to a clinic, especially in areas that are very remote. And so it's actually really important to continue with feeding and breastfeeding, because the earlier you're able to introduce food to children, there have been studies that have shown that early feeding and breastfeeding have actually reduced the severity of illness. And trials in Bangladesh have shown that rice-based ORT, which can be prepared at home by just boiling rice and removing the liquid on top and feeding it to children or those that have cholera, have been extremely effective in reducing the severity of illness, shortening the course of diarrhea and reducing the volume of diarrhea. And this is important, again, in areas where individuals are not able to access a clinic. In Haiti, there have been many, many deaths in the mountains and in the rural areas, and people have really been unable to access a cholera treatment center or a cholera treatment unit. And many programs have sent community health workers to those areas, teaching populations how to prepare ORS at home. And I think this is extremely important in terms of public health measures to implement, because especially in areas that are so centralized in terms of their health care or access to care. So let's talk about what happened in Goma. So as you know, the Rwandan genocide took place in 1994, and it was a result of a lot of tension between two major tribes, the Tutsis and the Hutus, that had been present for many, many years, and it culminated in this genocide. And I think the estimated number of deaths was about 100,000 individuals. As a result of the genocide, a lot of refugees moved to eastern Congo, which was then known as Zaire, and it's estimated that 1.2 million refugees moved to eastern Zaire at the time. And local capacity of both NGOs and the government was really overwhelmed, and as a result, this was classified as a humanitarian disaster. Unfortunately, the crude mortality rate was about 20 to 30 deaths per 10,000 per day. And there was a cholera outbreak that started there. And initially, during the first month, it's estimated that 58,000 to 80,000 cases were counted during that first month, and there were a total of 45,000 deaths. And I'm going to look into some of the reasons why that mortality rate was so high and why they had such a high case fatality rate. So thinking about just epidemiologic factors, the case fatality rate was estimated between 14 to 48%, meaning so case fatality is basically the percentage of people that have the disease that die. And it was as high as 48% in specific refugee camps. And there have been many, many papers that have been written to evaluate why the case fatality rate was that high. One of the factors that we looked at was improper cholera management. Unfortunately, the protocol for cholera management was not followed. Typically, when you're rehydrating, giving IV fluids, you want to use either normal saline or lactated ringer. Unfortunately, dextrose was used to treat cholera cases. And dextrose primarily just has sugar, basically, and doesn't really replace volume in patients that are dehydrated. But also, I mentioned the importance of looking at resistance patterns. A lot of antibiotics that were used during the epidemic were actually resistant to cholera, and therefore patients were not receiving the care that they were supposed to get that was appropriate. In addition, looking at other factors, the government decided to move refugees to a different region in northern Kivu where there was no surface water available, and unfortunately, this was after the epidemic had started, and many actually died en route without having access to treatment. They were walking, they had diarrhea, and they died en route, which is extremely unfortunate. Access to clean water was another factor. Refugees drank from Lake Kivu, and Lake Kivu had been infected with cholera at the time. And according to SIR guidelines, you want to give 15 to 20 liters per day to each refugee, and it was estimated that there was going to be a need of 5 million liters of water to provide adequate water to every single refugee. Unfortunately, the amount of water that was provided was only 400,000 liters, and that's a large, that was underestimated. In addition, there were no latrines. Because the terrain is volcanic in nature, it made it very, very difficult to dig latrines. So let's compare that to the epidemic that took place in Haiti. So there were a few cases of acute watery diarrhea that were seen, first noticed by Cuban physicians that lived in the Artibonite area, which is in around the north of Port-au-Prince. And this was first noticed in October 2010. And these cases were subsequently diagnosed as cholera by the national laboratories in Haiti that were assisted by the CDC. So we know that a large earthquake took place in January 2010, and as a result, 1.5 million people were displaced from this earthquake. And this is considered to be a perfect storm for a cholera outbreak, given the fact that there was displacement, there was lack of access to clean water, lack of access to latrines. And as of December 2012, according to the Ministry of Health in Haiti, MSPP, there have been about 8,000 deaths and 600,000 cumulative cases. So why was this a perfect storm for a cholera outbreak? Looking at Haiti, Haiti already had a very weak infrastructure. Before the earthquake, only 50% of Port-au-Prince residents had access to latrines, and 1/3 of Port-au-Prince residents had actually access to tap water. Haiti is considered to have very poor water security. It's ranked last in the world. Most inhabitants don't have access to clean water. They don't have latrines, and it's a really poor country. Recently, I think there were statistics that came out and basically placed Haiti as being one of the poorest, or the poorest country in the world. So before the earthquake, there were already various factors that were in place that were not conducive to being able to respond to a cholera outbreak. So, there's been a lot of controversy about the role of the UN and whether or not the UN was responsible for introducing cholera. We know that the cholera strain was linked to UN peacekeeping soldiers from Nepal. There had been an outbreak in Nepal prior to the earthquake, and a lot of investigations took place. They were able to link the two strains, and there has been a lot of controversy about this because recently I think there was a group in Boston that wanted to sue the UN. But I think there was a recent article in the New York Times saying that the UN was in fact not responsible and they had immunity because of the UN. And there's been a lot of tension, I think, in Haiti as a result. This is a picture taken at the Ministry of Health Facilities, MSCP, and it says ONG, so NGO plus MINISTA, which is MINUSTA, UN is equal to cholera. Basically, they're saying that MINUSTA was the one that brought cholera in, and right next to that it says it crosses MINUSTA out. So, people have various opinions about this. And it isn't very clear who was responsible. I don't think you can say that somebody was responsible because we know that there was a Haitian company that actually dumped excreta from this UN base into the Artibonite River. So it's really hard to place blame in the situation.
I have a picture of that truck actually dumping that into the river.
So let's talk about the cholera vaccine. This has also been a subject of controversy. So the WHO recently revised its position in 2010 on the cholera vaccine. So there are two major cholera vaccines. There is Dukoral, and the other one is called Dukoral has been available for the longest time. It's known to be 85% effective. Shanko is 67% effective, but it's an old vaccine and it's less costly. The cost of Dukoral is about $50 to $75 per dose, whereas Shanko is 89 cents per dose. Shanko is actually produced in India, I believe. and just recently was made available. So the protection in terms of just duration of efficacy is 3 years. Both vaccines require that you receive 2 doses, and you only achieve protection after the 2nd dose. So what are the challenges with the cholera vaccine? So thinking about epidemics and thinking about various areas and settings that are at risk for cholera epidemic, I think the first thing you want to think about when you want to prevent an epidemic or an outbreak from occurring is, okay, is it possible to distribute a vaccination? You know, there have been many diseases that have been eradicated as a result of vaccines, such as smallpox. And I think, you know, polio is one that is still around, but you know, there have been a lot of public health measures, a lot of efforts to try to get rid of polio by distributing vaccines to everybody. And so the thought is, because cholera is an illness that affects poor countries where there's poor infrastructure, is, you know, would distribution be a solution to getting rid of cholera? And so there are a lot of challenges with feasibility of distribution. Until recently, there was only the injection that was available, and having to distribute the vaccine in the form of injection is very, very difficult logistically, because you have to think about storage, you have to think about actually purchasing needles, and the oral vaccine is it's a lot easier to distribute compared to the injection. So availability is a major issue. There are only 400,000 vaccines available. WHO is trying to increase that right now, but until recently there were only 400,000 vaccines available. Partners in Health recently did this mass distribution in Haiti where they distributed 200,000 vaccines. So another thing to think about is it actually differs from basic needs. When you have an epidemic in a refugee camp, in an internally displaced people's camp, you don't have access to clean water, which is a basic need. Given the cost of the distribution of the cholera vaccine, I think there is whether or not it's cost effective, whether or not it's worth distributing. People don't have access to basic things such as latrines and clean water. So there was a trial, a cost effectiveness trial that was done by a group led by Efficacy, and I put the reference below. And this was actually published in JAMA a few years ago. And this cost effectiveness type, and their conclusion was that if the cost of the cholera vaccine fell below 22 cents per dose, preemptive therapy with mass vaccination would become a cost-effective option. If the cost of the vaccine were to fall below 16 cents per dose, the combined strategies is expected both to cost less and to prevent more death and treatment alone. Unfortunately, we're not at a point where the cost of the vaccine is either 22 cents or 16 cents. It's now 89 cents, and we don't have enough available. So those are things to think about when thinking about distribution of the vaccine. So I'm going to talk about other public health measures to implement in the setting of an epidemic, and this is an epidemic curve of cholera. And I obtained this figure from Oxfam. And so when you're actually thinking about implementing public health measures, you do measures based on various times during the epidemics. Right when the well, at the beginning of the epidemic phase, the number of cases goes up exponentially, that's the epidemic upward phase, and you have a little lag, and then finally you have the post-outbreak epidemic. And I think you're actually implementing measures or trying to deal with an outbreak. So during the pre-phase, so going back, it's looking at the endemic pre-outbreak phase. Understand changes in climate, mass
Hey, Linda, can we stop you for just a second? I hate to interrupt you. We're having some trouble hearing your audio. Just wanted to see if that was a concern the other participants were having, if it was just our room. Can everybody hear okay?
No, she was breaking up.
Okay. So should I go back?
Just do that preparedness slide again for us in its entirety. That would be helpful. I think we lost you maybe from your cell phone or your phone reception or something like that.
Okay, but you can hear me now.
Yes, we can. Thank you.
Okay, perfect. So talking about preparedness, things that you want to implement are, just engaging stakeholders, primarily the Ministry of Health, other partners, other NGOs, and you want to collaborate and think of ways in which you can all respond to the epidemic together. You want to understand sources and accelerators that would cause an increase in patients that have cholera. For example, we know that climate plays an important role in having an outbreak or having a surge. You want to prepare a contingency stock. You want to raise awareness in the community. You want to make sure that there's a safe water supply. You want to make sure that you have a way of actually disposing of the excreta very safely. And you want to put into place surveillance and have active case monitoring, as this will guide your response. So other public health measures. Especially when an outbreak starts, you want to do direct health assessments. The first thing we do is to actually make a clear case definition of what cholera is. WHO standard case definition and also NSF. According to WHO standard case definition, an area where disease is not known to be present, rehydration, water diarrhea, to think about cholera. It's a cholera epidemic. 5 years old or more that develops acute watery diarrhea with or without vomit for cholera. I want to confirm the cases by getting laboratory confirmation, if possible. And according to in an area where there is a cholera epidemic, any patient presenting 3 or more liquid stools and or vomiting for the last 24 hours should make you think about cholera. And so preparedness stage to focus is really surgery takes place, meaning doubling of the number of cases over 3 consecutive weeks. The attack rate of 0.6%. The attack rate is basically the number of people with cholera divided by the total population times 100. So as you're intervening, as you're designing your focused intervention, you want to think about demographics, who's affected by cholera. And you want to think about vulnerable patients, mainly children under 5, the elderly, pregnant women. You want to be able to focus your interventions on those individuals. Looking at epidemic patterns, based on your location and based on the population that you're treating. So I'm going to start with the last column, so a closed situation, a refugee camp. So the population density in this area can be high. You have a large number of individuals that are living in a closed area. They're not very mobile. So the attack rate is going to be pretty high, 1 to 5%. And the peak is usually reached after 2 to 4 weeks. And then the epidemic duration can be 1 to 3 months, the case fatality rate of less than 2%. In an urban slum, the second column, and this makes you think of Cité Soleil in Haiti. So Cité Soleil is a large urban slum where Samaritans Purse is serving. There is currently a clinic. There also was a cholera treatment center that Samaritans Purse set up at the beginning of the cholera outbreak in Haiti. And thinking about various factors that will influence the epidemic, the population density is usually pretty high. The population is pretty mobile. The attack rate is going to be 1 to 5%, as in a refugee camp. The peak is reached after 1 to 2 months, and the case fatality rate is 2 to 5%, and the epidemic will last about 2 to 4 months. If you are in a rural area, things are extremely different. The population density is lower. People are more scattered. The population is very mobile. The attack rate is going to be lower, 0.1 to 2%. The peak is reached after 1 to 5 to 3 months. And the case fatality rate is less than 5%, and the epidemic duration is about 3 to 6 months. It is a little bit longer. And I'm wondering if this is actually related to lack of access to care as opposed to these other areas. When you think about Haiti, and Tom knows this very well, those rural areas were very difficult to access. And you know, there was a lot of activities regarding community health workers doing a lot of education. And the number of deaths that were reported in the rural areas was actually probably lower than the actual number, just because of the reporting system that wasn't very efficient at the time. And they've made a lot of progress with regards to surveillance in Haiti. So you also want to think about an exit strategy, and this is very important. As you are closing up your CTC, closing up your CTU, you want to think about just being able to sustain the response by linking your cholera response with country programming. So you want to work very closely with the Ministry of Health, which we did in Haiti. And as you're thinking about further outbreaks and further response, you want to make sure that all these systems are in place. Surveillance, mobilization, supply chain, and training for community health workers, which has been extremely beneficial, I think, in Haiti's case, because people health workers access remote areas where clinic. Tiffany did an extremely great job. And this clinic was actually run by Haitians by the time.
Hey, Linda, I'm sorry to interrupt you again. I think we lost the last 20 or 30 seconds. If you could go back and repeat that one more time, that'd be helpful for us.
Sure. In addition, you need to improve local capacity to manage public health activities, but also you want to continue with hygiene promotion. So what is WHO's position on the cholera vaccine? And this again, as I mentioned, has changed in the past couple of years. They recently released a report talking about, and the title was Integrated Response to Cholera Outbreaks and Large-Scale Humanitarian Crises. And they recommended that national policies be developed in each country, but also that each country should try to develop a stockpile for the cholera vaccine, where 20% of the stockpile would be used for emergencies and 80% for prevention. But also they recommended that more funding be available for the oral cholera vaccine, which is a lot easier to distribute. So I wanted to end there, but also kind of start a discussion about the cholera vaccine. And my question was, based on what you know about the cost effectiveness, efficacy, and duration of protection, do you think there is a utility in distributing cholera vaccines in a refugee camp or an IDP camp? If you could answer yes or no, and it would be great to have a discussion about this to see what people think.
Yeah, and actually that's great, Linda. And the way we capture responses is if those of you that are in the room, the virtual room, would just look above your name or in the participants list towards the top, and the little check box with the box around it, the check mark with the box around it, click the yes or no, and that'll actually log our responses so we can continue to have a good dialogue on yes or no. There you go, Linda. Thank you for logging that. And the rest of you can just follow suit and just log your vote there, either yes or no, by the little check box at the top of the screen.
Another box. Another box. Linda, we needed another box that says depends. And that's not adult diapers.
And great, and go ahead and vote on those poll responses for the participants in the room, and then let's have a discussion about why yes, why no, and why it depends. Give you a couple more minutes to vote, and then I'll actually display the results. So if you could, go ahead and Again, at the top of the participants list, the little box with the check in it, either choose yes or no based on Linda's question, and I'll share those results in a minute. I'll publish them to our main screen here.
Maybe a no vote is undecided.
All right, 10 more seconds to vote. If you could, go ahead and jump in there, log your response in a few more seconds. All right, Linda, I'm going to display these results for you, and we'll publish these so you can see kind of just real quickly how they ended up.
Okay. So it looks like the majority of people said no. So 33% of the people said no. 13% of those that responded said yes. So I want to ask those that said yes, you think that there might be some utility in distributing the cholera vaccine. Could you please tell me why?
Pretty quick on her mic.
And remember, this is a dialogue, so we certainly encourage you to make sure your phone is unmuted or your microphone is unmuted at this time, and certainly chime in and be part of the conversation.
Dr. Linda.
Linda, I can start part of that conversation. It's not that I voted yes or no because we're sitting here in a room of undecided. So I have a few questions about the vaccine, and maybe you might be able to answer those. One is it takes 2 doses. Do we know how long the doses are spaced apart, and do we know how long after the second dose it takes until immunity becomes partial? Because with the vaccine, the literature that I've read says that it's about 75% effective.
Correct. So based on which vaccine you have, so the efficacy is about 65 to 85%.
Right.
The temporal vaccine is 85% effective, and the Shankle vaccine is about 67%. Mm-hmm. And I think that changes whether or not you're in an endemic versus epidemic setting. So the second dose is given approximately between, I think, 2 weeks to a month after the first dose is given. And protection is achieved after the second dose, so approximately a month after the first dose is given. And the duration of efficacy, as mentioned before, is about 3 years.
And Laura, it looked like you might have had a comment. Did you want to add something to the conversation?
Yeah, I just was asking about how long the vaccine protected for, and Dr. Linda answered me that it was 3 years. But I was getting ready to ask, do you think that the refugees would actually come back for the follow-up shots? Or, I mean, how would you make that a mandatory? How would you ensure that people would come back and make sure they're getting every shot in the series?
And that's a good question. And I think when Partners in Health launched the distribution of vaccines in Haiti last January, one of the major problems or the major concerns that people had was nobody would come back for their second dose. And they actually recently published the results of the trial they did, and it sounds like almost 90% of individuals return for that second dose. And it really depends on what the setting is. If you're in a refugee camp, then you have a good monitoring system. Not everybody is mobile. You're able to distribute the vaccine and come back and distribute the second vaccine if everybody's still present. But if you're in a situation where there's war, for example, and refugees are a little bit more mobile, they're moving from place to place, it might be more difficult to give that second dose. So I think it really depends on the setting.
And if I'm not mistaken, Linda, in Haiti, they did a mass vaccination. In fact, the MSPP claimed that they, or the MPSS, that they had greater than 90% recovery of their whole entire population in that campaign, and yet we've seen no difference at all in the endemicity of the cholera.
That's correct. That's correct.
Yeah.
Linda, this is Betsy, and I'm wondering, do you anticipate the same return rate, such a high 90% return rate for the second vaccine, as we get farther and farther away from the epidemic? We saw as you know, in our hygiene education and cholera prevention education, and then usually high rate of behavioral change, much higher than you normally see in hygiene education. And the theory, or the hypothesis, was that that was based on fear, because people were living in the midst, they were seeing the results, and it was affecting everybody personally, with friends or family dying or getting sick. So they were scared of what would happen. So that's a big motivator for change. But as we get farther and farther away from the thousands and hundreds of thousands of people becoming infected, I'm wondering how you anticipate that will affect the return rate on vaccinations if there's future campaigns.
That's a great question, and I think it definitely does play a role. I think if you're not in an epidemic setting and you're not seeing people actively die of cholera, I think the return rate is going to be lower. When you look at just basic numbers, the percentage of people that have been vaccinated in Haiti or other countries that are considered to be low-income countries, it's pretty low. I don't have the exact numbers. I know it's probably less than 50% of all children who don't receive. I think it's less than 50% of children who have not received all of the vaccinations that they're supposed to receive. And so, just given that, I think you're absolutely right. I think the vaccination rate or the return rate is going to be pretty low if you're not in an epidemic setting. That's a very good point.
Yeah. The other follow-up question, Linda, is based on research. Do you have an estimate of how long we can anticipate that high return rate? I'm wondering, particularly in light of disaster risk reduction measures, you usually see a pretty high return rate, but it's usually separated by generations. So you see people actively participating in disaster risk reduction methodologies within the same generation of a major disaster. So, for instance, in the same geographic area, so for instance, in New Orleans, in 1965, there was Hurricane Betsy that was almost as bad as Hurricane Katrina. And so apparently it had been about 40 years between the two hurricanes, and it was just enough time. They said that it happened 10 years before. At 30 years, people still would have practiced because the memory was there. But the new generation hadn't passed down the memory of there was an evacuation. There was a very low evacuation rate. So I'm wondering if you think the same principle would apply here, that you'll still see high return as long as the current generation has active memories of the cholera epidemic.
I think that's also a very good point. I don't think we can get we're able to get any evidence right now, concrete evidence of that in Haiti, because the epidemic is still ongoing and we're slowly progressing into an endemic stage. But I think you're absolutely right. I think based on the generation that has been exposed to the illness and what their experience is, there might be less of a response within that population. And those are things to think about when you're thinking about implementing policies and implementing public health measures, such as a cholera vaccine that is extremely costly. So in addition to just the cost effectiveness and factors such as protection, you want to think about those other factors. Very good.
Linda, a lot would come into this, into this equation here. If I were in Haiti prior to the cholera outbreak, post, the earthquake, and we were to go into our refugee camps or IDP camps there, definitely there wouldn't be any consideration of using cholera vaccine because there was a 100-year gap in any occurrence of cholera in Haiti. So, even the thought that, yes, we knew that the population was predisposed to an epidemic because of their dislocation, because of the stress that they continued to be under, and because of, crowding into the unsanitary camps that particularly were found in Port-au-Prince. It's interesting that the epidemic didn't start in Port-au-Prince, it started in the countryside. There would be no consideration of using a vaccine in a situation like that. You take, Zaire or DRC on the other hand, and you had a situation there where the cholera was endemic. in the area. We know that it pops up from time to time depending on the climate and the weather. In the population there, it comes back again year after year. And so given a refugee camp or an IDP camp situation there, especially if it were when the climate is conducive to the spread of the disease, then you'd have to really strongly consider whether or not you wanted to give the vaccine. You know, you get down to cost comparisons and whether or not it's effective, and what, you know, I really love it when people say, well, 22 cents a dose makes it worthwhile, because to the person who died of cholera, 22 cents or $10 is not a consideration. So it all depends on what, you know, funds you have available and what the history in the area is, and then what the, you know, what the climate, the time of the season that you're in is as to whether it would do. I would use a cholera vaccine in a refugee camp setting, and particularly the kind you were describing in Zaire at that time of year, given the fact that cholera was there and endemic. And so the threat of it, you know, the probability of an outbreak in those camps was very high. Mm-hmm. Where the probability of an outbreak of cholera in Haiti was next to zero. Okay.
Does anybody else want to say why they would choose to or not to provide a cholera vaccine in a refugee camp or IDP camp? And thank you, Tom. That was great.
Also, it depends on the resources available. If you have access to the vaccine, or whether you have money that you need to be spending on other things, and more important things such as basic hygiene and sanitation measures.
Lisa, could you repeat that? We didn't hear the question here.
Yes, I was saying that it depends on the resources and what you have available, whether you have immunization vaccine available, and whether you have enough money to do the basic hygiene and sanitation measures that are probably more important in that setting.
Yeah, I agree.
Absolutely. I think availability, but also whether or not other basic needs are being met, such as water and sanitation. Those are important factors. So I think I should have added a third option. It depends. Anybody else? And does anybody have an opinion on the UN's position? I know there has been so much controversy about whether the UN caused cholera and whether they should have contributed to the response by giving money to the victims. I think I'll try to send that article that was recently published in the New York Times, which is a great piece. But I think my response would be it's very complicated. I don't think you can point a finger at an institution for causing this outbreak, but rather coming together, as an international community to try to respond by collaborating. I know there's been decreased funding for cholera in Haiti, and there's still a lot to do, primarily in regions that are very remote. So if anybody has any ideas as to, what to do next.
One thing just to add, the UN did respond, not with money to victims, but IOM provided ringer lactate to all of the NGOs for almost the first 6 months. The UNHCR provided or led cluster meetings. WHO provided technical assistance. So there was UN response, just so we state that. Most people know it, but just so it is stated that they did respond, but just in their typical role, not extra, not in room. So I have a related question to, and would love thoughts. A lot of you will know, and if you haven't seen it, I'll be happy to send it around. but a couple of weeks ago, the Haitian government published a plan to eradicate cholera. It's a 15-year plan.
Yes.
Focused on safe water interventions mostly. It has to do with water and sanitation. It's the majority. There's also some clinical interventions proposed, but the majority of it is wash-related. But it costs several $billions, and they have right now 25% of the funding for it. But the plan was published as their proposed plan for the eradication of cholera. And I'm curious on thoughts or responses to that.
I have not read that plan. This is Tom. I haven't read the plan. I would like to, a 15-year time period for eradication of cholera, given the current economic status and the fact that that Haiti remains the most poverty-stricken country, at least in the Western Hemisphere, if not in the whole world. That I would doubt their efficacy. It's great for an MOH to be able to publish a plan, and we know a lot of them out there publish lots of plans, but having the resources and the wherewithal to follow through on them is a different story. A 15-year plan is a long time to pursue a goal, and as you said in your previous things about we get out a few years and there haven't been many deaths, it is the impetus to going to, to remain there for it. I personally do not believe they will ever eradicate it, because it's not eradicating cholera, the disease, it's eradicating cholera, the organism, from the environment. And the estuarian waters around Haiti now have that VL-Tor cholera in them. It's an inhabitant of estuarian environments. It exists very well without in the involvement of humans, and goes on in the muddy bottoms and the salt water and the nutrients that are available in that environment. In fact, it is thought to be necessary to the reproduction of some of the copepods that are in the area. And so it's there now, and my estimation is it will always be there. Since they're largely the coastal populations are largely dependent upon crabs and clams and whatever else they can harvest for food, I think it's going to be reintroduced every time that the seawater temperature raises up and the salinity drops because of rainwater being coming in from inland. Well, and I think you'll continue to see it break out around St. Mark and around the mouth of where the Artibonite dumps into the bay, into that bay. I forget what the name of that bay is. But I think it's there for good, and I think a lot of help. It's admirable they developed a plan, but I think that the plan is very limited in scope from the standpoint is they're dealing with humans and not with the environment where the organism now resides.
Absolutely. I also I know that I haven't read this specific plan, but I know that the Haitian government decided to integrate cholera care within various hospitals and get rid of CTCs and CTUs. And last December, I was in Haiti for about 10 days and worked with CRS and Hopkins, and we evaluated a couple of hospitals. Adequate. It's not a simulation we did, and unfortunately, other hospitals were still unable to not have a cholera surge, or in terms of the way they function and the logistics, we're still not able to adequately deal with the surge based on the simulation results. And this is unfortunately despite training that CRS had done for almost 2 years. And I think, in addition to what Tom said about cholera being there for a very long time, I think they have to think about being able to build capacity within various communities, within various hospitals. I remember when we closed our CTC in Cabaret, we donated a bunch of our supplies to a hospital that was close by, and they said they would be treating cholera. Unfortunately, a couple months later, we went back and we asked them, "Are you treating cholera?" And they said no, because they still have the supplies. And so there are other things such as corruption, And there's a variety of factors that come into play in addition to just being able to provide clean water.
Yeah, absolutely, Linda. The other thing is that, you mentioned that the epidemic was still ongoing, because there are still communities up in those mountains where it has not reached, and it will reach them. And where it is still ongoing is down in that the southern peninsula, out on the end of that particular peninsula. In other areas in Haiti, it has now become endemic, and it will be there for, I just don't think that the wherewithal is there within that government to carry out a one-year plan, much less 15-year.
It's almost 10 o'clock. Is that when we're supposed to end?
Yes, we're, just in terms of group feedback, did anybody have any closing questions or comments, additional comments that they wanted to make?
What's the red on Mary Lou?
Looks like Mary Lou's got her hand raised. Mary Lou, go ahead.
I have a question for you, Linda. But first I wanted to say, I see Lee McCluskey's name on here. Hi, Lee. I haven't seen you since the earthquake. Good to see your name there. But my question is, there's been, I haven't seen anything recently, but a few months ago there were discussions online with various groups talking about ORS or ORT and the fact that it is really not being recommended by WHO anymore to have homemade ORS made because of the dangers of getting too much sodium or various ingredients in it. And I noticed in your presentation, Linda, you talked about how it had some really good results in one of the countries based on some of the research they had done. Have you heard that, and does anybody else have any comments on that related to making or not making homemade ORS versus using only the manufactured version of it?
So I had a conversation with Dr. Greene about this several months ago, and he basically published a lot on oral rehydration therapy, and he actually disagrees with the WHO position, and I think the formulation of ORT is different, whether you're looking at the WHO formula compared to others. And he thinks that the WHO formula isn't necessarily the correct one, and I don't know if he was saying that because he has doctors, he obviously done a lot of research on this, but he says that he really thinks that the home-based formula is extremely important because a lot of times, families, especially if you're living in a rural area, a remote area, in a poor country, you can't afford to buy ORS. And if you can make it at home and administer it to an infant within the first couple of hours of onset of symptoms, I think you're able to save a life quickly by giving ORT. So I don't quite understand why WHO would say not to give it if providing some type of hydration would potentially save life. I know that there are different formulas based on the amount of glucose versus sodium, and many, many discussions on whether or not one or the other is more efficient. But I think if you're able to save a life quickly by just giving some type of oral rehydration, I think that's probably more beneficial. I don't know if the different solutions cause complications, but I would assume that just giving hydration quickly is probably more beneficial than not giving anything.
Yeah, Linda, I agree with you 100%. And there are places in there's remote areas where they won't ever get, packaged ORS too. And so if there is the possibility of having people be able to put, something together like the home-based, ORS, then if it's there, use it. The other thing is I think we need to be cautious in that the mother doesn't think that because she has put something together and starts giving her child, she should delay in getting the care if that is available. You know, they can use that en route to care, but they shouldn't be taught that, you know, to use that in lieu of care.
Right.
Absolutely. Absolutely.
Yeah.
This is Betsy, and I've been following the literature on this over the past several years, and there were several articles published that Mary Lou's referring to about the dangers of homemade ORS, but there have been competing articles or articles with the exact opposite opinion published since then. And what I anticipate that we'll see over the next year is that it neutralizes it out, but that I expect a common or a more unanimous approach to standardized training on making ORS, because I think when you look at really the issues that are associated with homemade ORS that were in the original publications, it seems to be more of a training issue than an actual use. If it's made correctly, then it's very effective. So I anticipate in the next year that with the articles being published that have the various opinions, that there'll be additional articles published the next year focused on the training of making ORS.
Plus the language of the culture. I mean, for a lot of cultures, for somebody living up in the hills and never sees anything, what is a teaspoon? You know, and, so it's the measurement that of the ingredients that creates the problem, and so coming up with a way of defining that that's culturally relevant is extremely important.
Absolutely. And I think you can also argue that if you look beyond cholera and look at traditional birth attendants, for example, and whether or not people are accessing skilled attendants in rural areas, you know, whether or not there's a value in training of skilled attendants versus, which has its dangers, but having women, the very fact that women have access to a skilled attendant who might not be the best trained person as opposed to having nothing at all to assist with their delivery has been controversial as well. And I think, you know, the conclusion is train people so that individuals that don't have access to care have access to something, but you should also put into place measures so that they can actually access a facility if there are complications. And so I think there's so many things in terms of training, in terms of providing access that should come into play when we're thinking about all these interventions.